Okay, we've got the recording started, and yes, we do have a quorum.
Excellent. Thanks for doing that, Brian. So call to order here, and our agenda items. We will review the meeting minutes from our February meeting. So those were all sent out to review, but please review them now. And if there's a pertinent motion, please make that.
A motion to approve the minutes from the February meeting.
I'll second the motion.
Thank you, Brian and Rocky. All in favor? Aye.
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 All opposed? Any abstentions? Hearing none, the motion carries. And now, Brian, if you could talk through our next agenda item, the P&T committee bylaws update.
Yeah, so it's been a little bit since we've had any changes to the bylaws, and in that time, the department has changed. The Department of Health merged with Department of Health and Human Services, and so it's necessary to make some updates just to make it up to date. So let me present that. And hopefully everyone's had a chance to review the updated bylaws. And again, most of it is just, updated branding or updating the meetings are now held virtually, not in person. And if anyone has any questions or comments, that would be helpful. And the DUR board has also done the same thing in their meeting last week.
Yes, Dr. Huffman.
Brian, are we required to have an anchor location?
I'm not sure if we are required to. We do list that the meetings will be held virtually, and in the case that a meeting is to be held in person, it shall be held and it's got the address of the Cannon building.
Would you review that with AAG? I just want to ensure. I know things got a little wonky during the pandemic, but I have several statutory committees that require an anchor location. I don't know if that applies here or not.
Okay. And in those committees, is it a requirement that it be designated as an anchor location or?
Mm-hmm. Yeah, and someone has to be there in person, even though the rest of attendees may be virtual.
Okay.
So I don't know if that's relevant here, but it's probably worth checking that box, maybe with Tony.
Yeah, I'll double check that.
Thank you so much. I think that would apply to DUR too.
Yes. So I will double check that.
But otherwise, these look great, but I just want to clarify that.
Yes.
So assuming that's not an issue, I would move to approve these changes.
Okay. And maybe we amend that motion to approve pending review by AAG.
Yeah.
That sounds great. So with that Brian proposed the motion. Dr. Hoffman will call that a second, if that's all right with you.
Sure. Yep.
I'd probably say put it the other way around. I think.
Okay.
Hoffman made the motion.
Okay. Thank you. Yep, we'll flip that. So great. All in favor?
Aye.
Aye.
Any opposed? And any abstentions? The motion carries and will be updated pending that review. Thank you. Next on our agenda, we have Dr. Nguyen with the DUR board update.
And actually, I'm going to be doing that in her place. Her voice is a little weak this morning, so she's asked me to take over that. So in February, the DUR board reviewed Sublocade utilization. In March, the reviewed gene therapy for sickle cell disease that included Lyfgenia and Casgevy. In April, there was a review of short-acting beta-2 agonists utilization. And this month, last week, they reviewed Montelukast utilization and boxed warning, as well as the bylaws update.
Great. Thank you for that. If there are any questions from the committee about the DUR board update, take those now. Otherwise, we'll move on to our next agenda item from Dr. Gonzalez, reviewing some anti-VEGF for us. Thank you very much.
All right, let me pull those slides up for you here. Here we go. Okay, so oral vascular endothelial growth factor inhibitors, which I'll refer to as oral anti-VEGFs, inhibit extracellular VEGF receptors on endothelial cells and most also affect other kinases. Ultimately, they reduce the downstream VEGF signaling cascade that stimulates angioneogenesis and progression of certain cancers. There are 10 oral anti-VEGFs approved in the US. Of these, cabozantinib is available in 2 formulations, tablets and capsules, which are each approved for a different set of indications. The remaining agents are available in a single oral formulation, either as tablets or capsules. Generics are available for sorafenib, sunitinib, and pazopanib. Altogether, oral anti-VEGFs are approved for the treatment of 8 oncologic disorders, including hepatocellular carcinoma, renal cell carcinoma, thyroid cancer, gastrointestinal stromal cancer, metastatic colorectal cancer, endometrial cancer, pancreatic neuroendocrine tumors, and soft tissue sarcoma. Of the oral anti-VEGFs, lenvatinib has the most approved indications with 4. Agents with 3 indicated disease states include cabozantinib, regorafenib, sorafenib, and sunitinib. Agents with 1 or 2 approved uses include pazopanib with 2, or axitinib, fruquintinib, tivozanib, and vandetanib, each with 1. Overall, there are 5 indicated disease states in common between 2 or more oral anti-VEGFs indications. However, since approved indications are also specific to use as first-line or subsequent line therapy, use with co-treatments or other clinical characteristics, indications may not fully overlap. For instance, for advanced hepatocellular carcinoma, lenvatinib and sorafenib can be used for first-line systemic therapy, while cabozantinib and regorafenib are approved for use after failing sorafenib treatment. Most oral anti-VEGFs are approved for advanced renal cell carcinoma, and those have the indication for first-line systemic therapy, whereas tivozanib is only approved for subsequent therapy following treatment with 2 prior systemic therapies. Sorry, I was supposed to click those highlights for you. The 2 oral anti-VEGFs approved For metastatic colorectal cancer, fruquintinib and regorafenib are approved for subsequent line therapy only after failing several other first-line options, such as intravenous bevacizumab. For gastrointestinal stromal cancer, sunitinib is approved after failing imatinib treatment, while regorafenib is indicated after failing both sunitinib and imatinib. For thyroid cancer, agents are approved for either medullary thyroid cancer, abbreviated MTC, or differentiated thyroid cancer, abbreviated DTC. Several agents have unique approved indications from others. Lenvatinib is the only oral anti-VEGF approved for advanced endometrial cancer. Pazopanib is the only agent approved for soft tissue sarcoma, and sunitinib has approval for the treatment of advanced pancreatic neuroendocrine tumors. Of the oral anti-VEGFs, only cabozantinib, as the brand Cabometyx, has a pediatric indication for thyroid cancer. Otherwise, package inserts for other agents declare that the safety and efficacy are unestablished in the pediatric population. Now I'll review the guideline placed in therapy for these agents according to the National Comprehensive Cancer Network, abbreviated NCCN. I'll also mention the head-to-head RCTs as available, since this evidence is supportive of the guideline recommended place in therapy. Comparative RCTs for oral anti-VEGFs are available only in the setting of advanced hepatocellular carcinoma or renal cell carcinoma, and are lacking for other indications. Head-to-head studies compared some of the newer agents to either sorafenib or sunitinib, which are the older anti-VEGFs. In the setting of hepatocellular carcinoma, sorafenib and lenvatinib are alternative first-line options for systemic treatment of advanced disease. These are recommended secondarily to the combination of bevacizumab with atezolizumab, which is an NCCN preferred regimen that has outperformed sorafenib. Regorafenib and cabozantinib are recommended only as subsequent line options consistent with their labeled indications. In the REFLECT RCT, lenvatinib demonstrated non-inferiority but not superiority to sorafenib for the primary outcome of overall survival. Lenvatinib did outperform sorafenib for some key secondary outcomes, such as progression-free survival and objective response. However, a meta-analysis did find a higher risk of grade 3 or greater adverse events with lenvatinib. Lenvatinib has also demonstrated better efficacy outcomes than sorafenib in a small RCT in patients with unresectable disease complicated by portal vein tumor thrombosis. Novel combination regimens are being explored for first-line therapy, such as cabozantinib plus atezolizumab. This is an off-label regimen that has outperformed sorafenib for progression-free survival, but not overall survival. So the NCCN has not yet included this regimen as an option. Regorafenib has not been directly compared to other oral anti-VEGFs. For clear cell renal cell carcinoma, axitinib, cabozantinib, and lenvatinib are among NCCN preferred first-line therapy as monotherapy or in combination regimens. They are also among subsequent line regimens for advanced disease. Pazopanib and sunitinib are alternative options for first-line treatment of clear cell RCC. Consistent with the approved indication, NCCN recommendations reserve tivozanib to subsequent line therapy only, following failure of first-line therapy. For non-clear cell renal cell carcinoma, cabozantinib is the only NCCN preferred regimen, while axitinib, lenvatinib, sunitinib, and pazopanib are alternative options. Newer anti-VEGFs have been compared to sorafenib or sunitinib, which were the usual care therapies in the past. Because several newer treatment regimens have demonstrated improved outcomes compared to sunitinib, the NCCN now recommends sunitinib as an alternative first-line option rather than preferred. And although sorafenib is approved for renal cell carcinoma, the NCCN no longer recommends that therapy. Axitinib plus pembrolizumab, cabozantinib plus nivolumab, and lenvatinib plus pembrolizumab are NCCN preferred first-line regimens for clear cell renal cell carcinoma. They have outperformed sunitinib in phase 3 studies for key outcomes of progression-free survival, overall survival, and objective response. Cabozantinib monotherapy has also outperformed sunitinib with respect to progression-free survival and objective response for first-line therapy of clear cell renal cell carcinoma and for treatment-experienced non-clear cell renal cell carcinoma. Thus, it is an NCCN preferred option for both histologies. Compared to sorafenib, sub-agents have demonstrated improved outcomes such as pazopanib for first-line therapy of clear cell RCC and axitinib or tivozanib for subsequent line treatment. The two approved oral anti-VEGFs for metastatic colorectal cancer, which are fruquintinib and regorafenib, were exclusively studied in patients with disease progression on standard systemic therapies. So the NCCN recommends these agents for later in-line therapy after disease progression on first-line regimens, some that contain intravenous anti-VEGFs. Oral anti-VEGFs are an option for advanced medullary thyroid cancer, or MTC, and for radioiodine refractory differentiated thyroid cancer, or DTC. For locally recurrent, unresectable, or metastatic MTC, vandetanib and cabozantinib are among NCCN preferred options. Off-label use of other oral anti-VEGFs can also be considered for symptomatic or progressing MTC if clinical trials or other approved therapies are not available or appropriate. For advanced DTC, lenvatinib is an NCCN preferred option. Sorafenib is an alternative, and cabozantinib is an option only after progressing on lenvatinib and or sorafenib. The use of other agents off-label can also be considered if appropriate. Sunitinib and regorafenib are NCCN recommended first-line options for unresectable SDH-deficient wild-type gastrointestinal stromal tumors. For patients with advanced disease who failed imatinib, sunitinib is a preferred second-line therapy, while regorafenib is a recommended third-line agent after failure of both imatinib and sunitinib. In certain scenarios, off-label use of pazopanib or cabozantinib can be considered. Regarding disease states for which only one oral anti-VEGF is FDA approved, sunitinib is among preferred options for advanced pancreatic neuroendocrine tumors. Pazopanib is a preferred option or alternative option for various forms of soft tissue sarcoma, and lenvatinib combined with pembrolizumab is recommended for recurrent endometrial cancer. Certain oral anti-VEGFs can be used off-label for advanced endometrial cancer or certain forms of soft tissue sarcoma. There were 1 to 2 off-label uses categorized by Micromedics as effective or as evidence favors efficacy. that are listed for several oral anti-VEGFs. These include axitinib for renal cell carcinoma, lenvatinib for endometrial cancer, pazopanib for gastrointestinal stromal tumors, regorafenib for osteosarcoma, and sorafenib for acute myeloid leukemia or gastrointestinal stromal tumor. While not included in Micromedics, LexiDrug lists 2 off-label uses for sunitinib, for soft tissue sarcoma and for thyroid cancer. Additional off-label uses that are NCCN guidelines supported, but that are not listed in Micromedics or LexiDrug are compiled in section 7 of the report. Oral anti-VEGF therapies share many warnings in common. As a class, they impede wound healing and are associated with a small elevated risk for hemorrhage, thromboembolic events, and hypertension. Nearly all have warnings for cardiac failure and or major cardiac events, posterior reversible encephalopathy syndrome, hepatotoxicity, and thyroid dysfunction. More than half of the agents have warnings regarding the potential for QTc prolongation, gastrointestinal perforation, renal failure and or proteinuria, or dermatologic related toxicity. There are also several warnings unique to 1 to 3 of the reviewed agents. So anti-VEGF therapies are not yet categorized as preferred or non-preferred on the Utah Medicaid PDL, other than the notation regarding coverage of the brand over generic for sorafenib and sunitinib. A non-drug specific prior authorization is currently in place for all anti-VEGF therapies. The NCCN guidelines are updated frequently. Some reviewed for this report have been updated multiple times within the last year. Overall, the NCCN guideline recommendations account for the head-to-head studies available for oral anti-VEGFs. In general, agents that are recommended with top preference by the NCCN for first-line therapy and that have the corresponding FDA-approved indication for the condition could be considered for preference on the PDL. NCCN alternative line or subsequent line therapies, or otherwise any oral anti-VEGF, could be made accessible as a non-preferred product via prior authorization. And just as a recap, this slide summarizes the approved agents for the respective condition that are NCCN recommended as a preferred first-line option. This includes certain oral anti-VEGFs for advanced renal cellular carcinoma, thyroid cancer, pancreatic neuroendocrine tumors, and soft tissue sarcoma. And of these disease states listed on this slide, renal cell carcinoma and thyroid cancer are among oncologic groups that rank in the top 10 for US cancer-related incidence or death rate. And although other oral anti-VEGFs may be NCCN recommended alternatives for first-line therapy of the reviewed disease states, they were listed secondarily in preference compared to agents on this slide or other agents in different drug classes. So I will conclude with that. Oh, and I'll just mention, we pulled data for these agents, and over the last 3 years, there were only 14 patients total on these agents. So very few people are using these in the fee-for-service population. And just looking at the last year, only lenvatinib and sunitinib were used. So just to give you an idea of utilization for this set of anti-VEGFs.
Thank you very much for that extensive review. Dr. Gonzalez, you anticipated my first question, the last blurb about utilization. So we'll open up to any discussion from the committee members here? Because I didn't see any public comment. I'll double check, but on the agenda. Yes.
Valerie, any sense on those utilization numbers, given how small they are, if that reflects that these diagnoses are being treated in a different way, or if we just have a very low number of these diagnoses in the fee-for-service population?
Yeah, I since we kind of look at things on a population level, I don't get to see on an individual level, you know,
Mhm.
all the medications someone may be using. So I'm not sure if people are being treated with other things, or I would suspect that maybe these diagnoses, because most of these that I reviewed for this group of drugs are more rare oncologic disorders. There are a couple that are a little more common, like thyroid and kidney cancers. So maybe our population is, you know, hasn't had these diagnoses as much.
Yeah, I have a couple of patients in the prison healthcare system on these agents, and so I'm very interested in understanding. You know, in our system, I know in Medicaid we don't look at cost, but in our system, we're paying for and providing the care, and so the recommendation when there's first line agents that are alternatives is
Mhm.
relevant for me. You know, if they're lower cost, but yeah, interesting. I'm curious about what the alternative treatment pathways are, if these actually reflect the real numbers of people with these conditions in the fee-for-service population with that
Yeah.
amount of utilization.
Well, for several of these indications too, there's lots of other preferred therapies as well. Like the some may include bevacizumab or like IV VEGFs, or just different types of cancer treatments, you know, not in this drug class.
Yeah, I think they've been gravitating towards orals in our population to get them back into the carceral setting.
Mhm.
And so we've just seen it going up in terms of orals. Interesting. Okay, thank you.
Yes, Dr. Siegfried.
Brian, there was no listing of what other states do in terms of this class of medication. Do you have any sense of whether they do any prior authorization?
I have not looked at what the other states have done with these drugs.
And my question, sort of related to the discussion here, if an agent is preferred with pembrolizumab or something like that, are those approval processes tied together, or would that affect that wherever the infusion approval is coming from, and that may be the same place? I was just curious if one begets another, then they run into approval problems that way.
I would expect that each the oral, the ophthalmic, and the IV would be have three separate PDL classes, and again for the IV and the oral, you know, pending whatever motion comes out of this meeting, but I would expect we would probably look to have NCCN recommendations to guide what we have as preferred. And that's what the motion was at the last meeting for the IV medications. And so if there is a difference where a drug is preferred in either IV or oral and non-preferred in the other, and someone was transitioning from one to the other, then I would expect a prior authorization process would take care of that.
Great, and that's what I expected. It looked like some of them were tied to a different, like PD-1, different class out of the anti-VEGF. So it seems like they selected this one for this, and I don't know But that answers my question. Thank you.
Mhm.
And appreciate the suggestion here on slide, I believe it was 17, as far as preference on the PDL. So we work to kind of make a motion here. If we're at that point, if there are any other questions, please stop me. But as we're making this motion, I wanted to make sure that the patients that have gone through already would be included in that. And it seems to be general enough as we look at NCCN recommended with top preference for first line therapy, and recognizing that can change fairly quickly, as you noted in the presentation. But I assume all of the patients from the last year would be captured appropriately within this motion. And I guess I don't think we have a great way to double check that, but just something to consider as well. So looking at the motion here, I had NCCN recommended all right, I'll start over. For inclusion on the PDL, recommend at least one agent that is NCCN recommended with top preference for first line therapy that has a corresponding FDA indication for that respective condition.
I second that motion.
All in favor?
Aye.
Aye.
All opposed? Any abstentions? And the motion carries. And then Brian, and I assume the hand raised was for the vote. Do
Yep.
we need a second motion kind of referring to that bullet point there for alternatives? And I guess that's the prior auth process, so we don't need to
Right.
have that as motion.
Yeah, I don't think a motion is necessary, because if something is second line or salvage, generally they're going to be going through those first line options first, and a prior authorization process is an appropriate way to handle second or subsequent line treatment approaches.
And there wouldn't be any concern about someone who's on established therapy being affected here. I know Dr. Siegfried, it's like the grandfather clause there. I assume.
Typically, we have grandfathering, and so if someone is currently on a therapy and the PDL changes, or we implement this PDL, I wouldn't expect any difficulties with continuing.
Perfect. And that was my assumption as well, especially given the low actual numbers of utilization. But I'm okay not making a motion there. We just want to make sure the committee feels the same.
I would agree with that.
And that's not a formal vote. That's an invitation for discussion. Hearing none, I believe we're getting close to wrapping this up here. So just a reminder, our next meeting is Thursday, September 19th, and the topic is hereditary angioedema. I'll make a motion to adjourn.
I'll second.
Thank you. All in favor?
Aye.
Aye.
All opposed? And any abstentions? Thank you very much, everyone. Have a great summer.
Thanks, everyone.
Thank you.